briefly be going through what we have done this far, what we need to do ahead, and if there are any points that require clarification, we can. I'm not saying that we are going to achieve the end, but we are trying to reach the end. And there are going to be certain jamming areas in between, and we are trying to circumvent it. And our objective is only one, that we move towards doing everything that is required to get a full accreditation under NABH 5th standard. That is the standard that is currently going on. And I have made a short presentation because it's not possible for me to keep talking without the help of some visual help, I would say. So I'll just share it now. Dr. Yuvraj.
Madam, are you able to share it, or should I just make you the host so that you just let me know?
Let me see.
If you're not able to share it, let me know.
Can you see it now?
Yeah. You can just maximize it.
Yeah, I have. I'm trying that.
Yeah. Yes, ma'am. Perfect.
Fine. So this is just a short review of the status update that we have reached at St. GS Medical College and KM Hospital with the support of with the support of the administration, the dean, as well as all the staff members who are concerned with going ahead with NABH. So I think all of us started off at the same time, Dr. Yuvraj. You would agree that you all started off as nodal officers. Then you had an NABH core team formation, and we expanded it to include a whole lot more members, and we identified a coordinator. Then we needed to have what is called as the NABH standards book and a guidebook. So there is a guidebook that is available on the NABH website, which costs about 6,000 plus 15 rupees, I think, 5th edition. So that guidebook explains how to interpret each of those objective elements. We know that there are 10 chapters. Each chapter has got some objective elements, and each of the objective elements, how it is to be interpreted so that the output becomes uniform. So then we also went ahead distributing the chapters to different key personnel in the hospital based on the core subject of that chapter. Then I think two of us did gap analysis using a consultant, private consultant, whereas I think Nair went ahead with doing a self gap analysis. Now the basic thing about a gap analysis is to understand that it will always be only a sample audit. Only certain areas would have been looked at, and it would not have been a comprehensive overall 640 elements ka gap analysis. So that we need to keep at the back of our mind when we say that these are the only gaps. Then the two important components that came out during gap analysis is the statutory licenses that we need to have with us, and definitely absence of documentation of a majority of practices. And during this gap analysis, certain problems with infrastructure and manpower requirement was also highlighted. So then we waited. There was this vacation time that happened during November. Then from December 2023 till date, what have we been able to do? So we have kind of almost all departments. I would say there are about 40 odd departments, 42 to be precise, including occupational therapy, physiotherapy, nursing, dentistry, etc. 2 or 3 departments are still left to come up to documentation. So in documentation, as per the format acceptable to NABH. So I think Nair has already appointed somebody who can help them through with the NABH, but it's important to understand this documentation is not any documentation. Documentation has to be as per the format that is required by NABH, and that is something that we can do better if we read the guidebook. So this will include our policies, this will include our procedures, this will include the forms that we're using or the formats that we're using, and this will include a whole lot of records that we need to generate as a consequence of all these policies and procedures. We have to define what are called as quality indicators as per NABH requirement. We have to form committees with defined roles and responsibilities. Then we have to meet. There is no two ways about this. We have to meet fire safety requirements. It is mandatory. Then we can kind of be appointed a facilitator in the month of mid-February, sometime around 13th of February. And then this process was hastened up because otherwise we were a little slow first in the uptake and then in the output. So after appointing a facilitator who has done a wonderful job, we have been able to move at a much better pace. And then we have had extensive discussions with various stakeholders on chapters 1, which is AAC, which is assessment, uh, access assessment and continuity of care. Then 2, which is on care of patients, and 7, which is on responsibilities of management. We have also had some amount of discussion on facility management and safety. So this is what we have done thus far, and hospital infection control, which is chapter number 5, is already on board in all of our hospitals. So that should not be an issue to comply with. Maybe it needs to be tweaked. So I want us to concentrate, or rather we have concentrated at KM on chapters 1 and 2, which is basically what the clinicians are expected to do, because it deals with access of the patients, assessment of the patients, the continuity of care that is provided, as also the care of the patients. So what are the outputs that are needed from these 2 chapters? First and foremost, maybe you guys have done this homework, I do not know, but there should be the scope of services that is available and displayed. And it has to be displayed bilingually. That means one language will be English, the other will be the local language, state language, which will be Marathi. And this should be displayed prominently at the entrance through which the patients enter the hospital. So it's also important to understand that it is not just about services that we give, but also about services that we do not give. For example, at KEM, we can say that oncology services are not provided. So each hospital will have its individual list of services that they do, services that they don't do, and both need to be displayed. Then in addition to this general display at the hospital, there has to be an individual specific display at the department office. So suppose you also have, or all of us have, an equal number of departments. Let's just say 40. Each department should have a detailed display of what services are being provided. So the patients who visit the department know that these are things that are available. These are the days on which it is available. This is the timing where it is available. And this is the location of the service that it is available with. So that is at the level of the department. So this should be visible to the patient. There are certain things which need to be visible to the patient and relatives, or those seeking care in the hospital. And there are certain things which can be displayed only at the level of the office internally. Then each department should have a manual. So like anatomy also should have a manual, though it is not directly related to patient care. So anatomy will have a manual which will have certain components which are common to all the manuals. So we talk about manuals for all the departments, including dentistry, nuclear medicine, occupational therapy, physiotherapy. Every single department which are listed in the scope of services should have their manual, including the engineering department, which can go as support services. So these manuals will have 2 components, or are having, the way we have prepared it, it has 2 components. One is the generic one and the other is the specific one. By generic one, we are talking about clinical care areas. So by generic, we mean manuals will have, let's just say that this is a department that also provides indoor services and not just restricted to OPD. So then it will start with the admission of the patient, right? So the procedure for admitting the patient in the department, the initial assessment of the patient, the time taken between admission and initial assessment, then what are the remarks that we are giving in terms of initial assessment, then what about the referrals for that patient in terms of blood tests, in terms of imaging services or any other services we need to call expertise from, say, neurology or cardiology for the patient. So what are the referral mechanisms? So all these procedures need to be described. And there has to be a common discharge policy, or what happens if this patient dies. And there has to be a topic on what are called as medico-legal aspects. So if it is a medico-legal case, does anything differ? And also one needs to take into consideration DAMA. So all these things, and transfer in and transfer out. So you could have patients who are transferred in from other hospitals. You will have patients who require to be transferred out from your own department or your own ward to some other ward. So all these things are what are described under the generic head. So if there are any questions in between, you are welcome to ask. The other thing is specific. So to begin with, like let's just say medicine department, right? The services that it provides is for all. So they have to list out the different conditions, so common conditions for which patients can come to their department. But you don't have to describe all these conditions, is what we have been given to understand. In the first year, it is okay to describe 2 or 3 common conditions. So which would be the routine one, and 2 or 3 additionally the emergency nature ones. So these are the things that need to be described in the SOPs for each department. And there has to be a separate SOP at the level of the casualty, There has to be a separate SOP at the level of indoor. There has to be a separate SOP at the level of ICU, and there has to be a separate SOP at the level of OT. So I think I have made, is this much clear as to what we have done? Then we talk of these indicators that need to be captured. And the reason why I have listed out the indicators is, before we register for applying for the full accreditation by NABH, we need to collect 6 months data and analyze those data for those 6 months. So we know where we stand. Nobody says that you need to stand here, but we need to know where we stand. And for that, we need records of 6 months. So these are in general the common indicators that we need. So one is, of course, those that are related to infection control, I think, which most of us probably are following: CRBSA, CLABSI, COTI, VAP, needle stick injuries, surgical site infections, hand hygiene, bed sore, surgical safety checklist. Now, for all surgical disciplines, please remember that this is very, very important to have surgical safety checklist for every single patient who undergoes surgery. Then we have the common ones like, I mean, not the infection control related ones, but the non-infection control related ones. These include adverse drug reactions, fall incidents. Fall incidents, these need to be captured. You can decide the format in which you want to capture it, but to begin with, we have decided to capture it in registers. One bada register of 200 pages divided into multiple sections, and in each section you capture this. So then we put the date. Let's say that today is 30th of April. Let's just say ward number 5. Ward number 5, total number of patients who were admitted and number who had a history of had a fall incident, right? So the numerator is the number of patients with the fall incident, and the denominator is the total number of patients admitted for that day. So this needs to be recorded for every single day. And if there is nothing, you just write nil. But for each date, there has to be an entry. Like 30th April, if there was no fall, just write no fall. But if there was a fall, then you record the fall. And in case we are recording the fall, just look at the last bullet in the same slide. In case we record a fall, we have to generate an incident report. So in the incident report, one does a root cause analysis. Why did this patient fall? Was it because there was no bed railing provided? Was it because there were two patients on the same bed and therefore there was not enough space for each of them to lie down specifically? So there is something called as a root cause analysis. Or was it because he had a postural hypotension, or whatever be the reason? Or was it because the floor was slippery? So there has to be a root cause analysis, and based on that root cause analysis, one has to prepare a corrective action report, right? And then if this continues to occur, that means that there is something that needs to be looked at more seriously, and we have to define a preventive action. So what exactly is corrective action and preventive action? I think your labs are already NABL accredited and they can be taken help of to define all these things. But remember that for all these indicators, if there is an indicator which is an adverse indicator, then it is important to generate an incident report. The incident report can be captured in the same register, or for each incident, we can have a file wherein the incident report is filed. Only thing is, we need to know that I have to look at the incident report for this incident in this particular file, and they have to be cross-referenced to each other. So similarly, we have adverse drug reactions. We have a near miss sentinel event. What is a sentinel event? An event that, what I have understood, an event wherein it leads to a disposition of 14 days or more. That means a patient has a fall, fractures the humerus, let's just say, and because of which that particular arm or hand cannot be used for at least a period of 14 days. That is a sentinel event. So anything that incapacitates either part or whole of the body for a period of 14 days or more is considered as a sentinel event. And sentinel event need to be recorded differently. I think your NABH facilitators will tell you in a better way, but these are the things that we are currently capturing. So, and that's the reason why I'm talking about this. Then, of course, medication errors. So, in medication errors, there is this concept of LASA, things that look alike and sound alike. Okay, so this list has to be taken from pharmacy. This list also can be vetted by the pharmacology department. We need to have this list displayed at the medicine dispensing counter in the ward and in the stores, so that there is no mismatch while these are getting dispensed between the different areas, because we have a central pharmacy, right? Then from the pharmacy, it gets distributed to the ward, to the OT, to the ICU, wherever. So at both these places, LASA drugs should be listed out and they should be kept separately. Similarly, When we talk about medication, which is not mentioned here, is there are certain drugs which go by the name of high alert. So there are certain drugs which we cannot always use, and there has to be specific indications for its use. And the second thing is narcotics. So if there is a hospital that is prescribing narcotics or giving narcotics to the patients, there has to be a separate narcotics policy. It is important to understand who is going to be responsible for this narcotics acquisition and what should I say, prescription and giving. So this has to be recorded separately. Narcotics has to be recorded separately. Then of course you have certain other quality indicators like extravasation of blood when you do an IV access and there is this that is happening. And then sometimes we have seen situations wherein the patients need to be restrained, right? So when there are restraint, when there is a restraint, so this patient develop a restraint related injury, that also needs to be captured. Then we have introduced many a times, even in KM, previously I used to see that catheters, whether it's a Ryle's tube or a urinary catheter, easy to remove, and accidental removal or what should I say, conscientious removal of these tubes also need to be captured. So these are just the list of indicators that I thought we were doing and I should share with you. And you can capture all these in a single register, or you can have an Excel sheet into which this can be done. But the problem will be who will feed all this. So we thought the best thing is to capture who is doing this currently. Both the residents as well as the nursing staff do this. So there is no clear, there shouldn't be in my very humble opinion, I would say, because things need to work. So there cannot be clear-cut demarcation as to this person has to do this person has to do this. So if we take combined responsibility, things move. If we don't, if we take restricted responsibility, things will get stuck at one point and we will never move ahead from there. Then I'm not giving a bhashan, please. So don't take it in that sense. I'm just trying to share with you what we have gone through as we were doing this and realize that we have to work as a team and there is no two opinion about that. Then in ICU, in addition to all those indicators that we spoke about, which we can consider as the ward level indicators, there will be additional indicators as applicable. So in the ICU, once a patient visits the ICU, what is the initial assessment time? Now, if you have gone through this NABH standards and the guidebook that I'm talking about, in the last section, there is something called as key performance indicators. And in that key performance indicators, there is mention of this initial assessment time. Is the time that is taken from the time the patient visits that particular area to the time that the initial assessment takes place. The initial assessment will be by two different categories of staff. One is the nursing staff, the other is the clinical staff. Right? So you could capture any one of these. You don't necessarily have to capture both. But in the ICU, it has to be the clinical staff. At the ward level, it can also be the nursing staff. And this needs to be recorded. This needs to be recorded. So we all have an indoor ward register, right? So in the same indoor ward register, we can have an additional column. And if there is no place for the column, since it is already well demarcated and well, what should I say, there are already columns there, you can make it a part of something that at what time did the patient come in and what time he was assessed. This is a key performance indicator. All the key performance indicators, I think there are about 32 of them, need to be captured. So it is important that we understand this concept of initial assessment. So this holds true at every single place, including the OPD. So OPD may, instead of initial assessment time, it will always be the time taken for that patient to come out, enters the OPD and comes out of the OPD. So that is something that we are looking at in the second phase. I mean, not immediately. Immediately, we are looking at the indoor patients and ICU. Then the other indicator that needs to be captured in addition to all the previous ones in the ICU is the return to ICU within 48 hours. So we said that this patient is fit for discharge to the general ward and then he comes back to the ICU within 48 hours. So there has to be a return to ICU and again there will be an incident report for this. Every single indicator which is not satisfactory will have an incident report and patients who require re-intubation. So these are the additional ICU indicators that we are talking about. Then what else have we done? So when we talk about scope, so there has to be a specific format, right? So first is what we decided that the scope should list out the SOP for the department should list out the scope of the department. What are the things that we are doing? It should have an organogram at two levels. One is the clinical organogram and the other is the administrative organogram. Administrative organogram will be common for all departments. Clinical organograms may differ. Like for example, we have, when we define the scope, in the scope we'll say we do OPD, we do IPD, we do OT, we do certain procedures, we have an ICU, right? So if that is the clinical scope of the department, then the staffing pattern for each of them will be different. So that needs to be captured, right? This is where that nurse patient ratio will also be reflected. If we are saying that in the ICU you need one nurse per two patients, and not for 20 you need one nurse per patient as per the nursing council recommendations, then those things will get captured here. Okay. So first is define the scope, second is define the organogram, third is define the staffing pattern. And once you have defined the staffing pattern, define or fix the duties and responsibilities of each of the staff categories. There are no names here. There should only be designations. Like for example, there will be a unit head, or there will be somebody below the unit head, which will usually be an assistant professor. Then there will be an SR, and then there will be the JRs, right? So this is the usual staffing pattern. And then you have the nurses, the sister in charge. So you have the nursing staffing pattern also there. So that also needs to be listed out. And you also need to list out the labor staff, because one fine day labors don't come, you know how much difficulty we have. So that should be there in the department SOP. Once that is done, also have a backup mechanism. Say suppose A doesn't come, then who will look after the work of A? So just a column where it says that the backup will be provided by, if JR1 does not, JR1 number 5 does not come, then JR1 number 6 will provide the services, something like that. Then you have what is the concept of crash cart. Crash cart is something that you all know better than me. So that is something that you use whenever there is an event that requires urgent attention. For example, a cardiac arrest, right? So what should be there on the crash cart? So I think the NABH facilitators that you have appointed will help you with what should be the contents of any of this that you want me to share. Please feel free to ask, or I would suggest that you please feel free to ask your own NABH coordinator. Maybe they will be doing a better job. I wouldn't know. The next point is something that you have to start working on from today, and that is the training for Code Blue and Code Red. Code Blue is unfortunate event leading to arrest or near death, and Code Red is fire. So इसका जो training है, whoever, Code Blue usually training can be provided by anesthesia. What we have decided is that the anesthesia, of course, Code Blue training तो होता रहता है, everybody says, but it's important that there is a record of the training that has been provided to all the people working in a given ward or OT or ICU. It's important to have records of training. So if we don't have for the previous, we can generate from now on. And this Code Blue training is usually something that is provided by the anesthetics departments who have been trained by under the American Heart Association, something to that effect, right? So we can have a set of trainers where, look, I don't know what is the strength of the staff that we have, but this Code Blue training has to be given to each ward at the level of each ward. So we all have at least 40 to 50 wards, if I'm not mistaken. In addition, we have some ICUs. In addition, we have OT. So we have a good number of areas which need to be covered. And there are not so many anesthetists who can drive the Code Blue. Right? So what do we need at the local level? Who can start this Code Blue thing and complete it? And when indicated, the anesthetists can come in. Anesthetists are required where the people in the ward would probably not know how to intubate. Now, in today's times after COVID, I think most of the clinical departments, I may be wrong, I'm not saying no. Most of the clinical departments will have someone who knows how to intubate. Right? So this Code Blue training initially for the trainers can be taken by anesthesia. Then those who have been trained can come back and train the whole department. I think that's the way we are looking at it, and that's how we are going to be doing it from 2nd of May onwards. So we are going to be preparing a timetable so that everyone has a proper certification of having been trained in Code Blue. And this is something your NABH facilitator will also tell you, that they raise a Code Blue. The NABH team, see, everything is being worked to comply with NABH, right? What to do, what is required when the NABH team comes to do the assessment. So in that context, when I say they will come and raise a code blue or they will come and raise a code red, that means that they will say that there is this code blue that's happening, and they will see how much time you take to respond and how well you respond. Okay, so it's important that you define this code blue well. It's important that you define the code red well. There are other codes also. There's, I think, a code yellow and code gray that can be seen later, but these two please start with immediate effect. Even if you start during vacation with some of the anesthetics that are there and the half staff that you have in the clinical side, it should be good. Then the next thing is every SOP manual should have the list of equipment that are required for patient care or for any other purpose. Like for labs, will have their own list of equipment. Radiology will have their own list of equipment. If you look at if you look at the first chapter, it's just not about clinical departments. It's also about lab departments, which are care of the AAC 6, 7, and 8. Then it's about radiology, which is AAC 9, 10, and 11. So amongst the 14 AAC 1 to 4, three things belong to the lab and three things belong to radiology, which they need to comply with. Okay, so every single department has to prepare a manual. Every single department should have a list of equipment in that, and this list of equipment should at least have accession code. Now I think most of us, for a majority of the equipment, they are under PMC with PM with TriMed, and TriMed has provided some kind of an RFID code that can be considered as an accession code. Okay, so you need to have an equipment register or an equipment log where you list out the equipment that you have. What is the accession code for that equipment? What is the make of the equipment? What is the model of equipment? What is the status of CMC and AMC? And what is the last calibration date? All quant equipment, and I'm talking even about the simple quant equipment like blood pressure monitor and weighing machines. If we are using it, they need to be calibrated. So it's important for every department to prepare a list of equipment that requires calibration and send the same to your engineering department with immediate effect and with a suggested cost. Matlab, what is the approximate cost that it will incur? So they know what kind of an action is to be taken. So each hospital can send it to their own and then they can decide how to work on it, because they will need to invite quotations and all those things will happen. And also the ISBAR handover procedure has to be described in the SOP. What do we mean by handover procedure? There's a concept called as ISBAR. ISBAR. I stands for introduction, S stands for situation, then B stands for background, A stands for assessment, and R stands for remarks and readback. So when I say introduction, so who is like, for example, the nurse has seen the patient or a doctor has seen the patient, and who is the patient? So who is the healthcare worker? Who is the patient is the introduction. Situation, what are the present complaints? So we all have this in the indoor record. We also have this in the OPD paper. Right, so the easiest thing that we thought we could do is ISBAR was followed and handed over to the next person. So this is not something that's happening now. This we need to put into practice. That means that at the end of every shift, I was told that there are certain departments where the residents are working 24/7. So there is nothing like a handover for them. But for the nursing department, there will always be a handover. There is a morning shift, an afternoon shift, and the night shift, right? So they need to just mention that ISBAR followed and handed over to this person, and the person who comes next will say that seen and seen. Is this clear? So this is a mandatory requirement for NABH. I'm just telling you the more complicated things that need to be featured into when we are talking about NABH. Then would you be interested in going through one of the SOPs, Dr.
Yes, yes,
Nataraj?
yes, ma'am. Yes, ma'am. And
Yes,
ma'am,
ma'am.
all colleges have joined. All our 4 or 5 colleges
Yeah,
people have.
fine. So what I can do is I can minimize this and I can go to. So I'm sharing. So this is just a general format for the SOP. This is a Word document, right? So every single SOP that we prepare will have a header. So header for that SOP will consist of every department will be provided with a code. So the NABH core team that is there can be called as the Apex committee, and each Apex committee can provide each department with a code, and that will be the department code. So this is the first time that we are doing it. So it becomes version number 1, and the date you generate this will become the version date. So we started off on the 1st of Jan. So we are writing it as 1/1/2024. So this is for dermat OPD that I've taken. So for all our SOPs, there is a format which again and again I'm telling you the same thing. Maybe your NABH facilitator will give you better inputs, but this is what we have done and I'm sharing with you. So the first thing is who is in charge of the manual? How is this manual being controlled? Every single document that is generated for the purpose of NABH is a controlled document. Okay, so there should be a responsibility assigned as to this is a document that is available, it is good, it is secure, it is in safe condition. The holder will maintain the current status. That means if you are coming out with a version 2 or an amendment to this version goes inside the cupboard. It becomes an obsolete version and only the current version is remaining outside. And who is responsible? The final authorization is by, of course, an accreditation coordinator, but it is always under the HOD. Okay. So you give the document name, then when did you start? You might have prepared it on the 1st of Jan, but you started implementing it from the 1st of Feb. That is acceptable. So then you give the document a name. So in this case, it will be standard operating procedure for patients attending the dermat OPD, date of implementation. It is prepared by a different set of people. It will be reviewed by a different set of people. It need not always be HOD, a senior level associate professor can also review this document. And then it will be issued by an accreditation coordinator. So every department or the institute itself can identify who should be the accreditation coordinator. So you can't have one person going through all the manuals of 40 different departments. So each department should identify their own. And final approval has to be by the dean. Is that clear? So every single document that we prepare has to be finally approved by the dean because she is the highest authority for our administrative or clinical organogram. Clinical organogram, you have the unit head or you have the professor and head depending upon their distribution. But the final approval is the dean for us because that is the administrative head and that has to have, every single document has to have the thing. Then what is the scope of department? That's what I said. So in dermat, in this case, this is an OPD. So you can list out the common conditions that they see. Then what are the other thing that I said, just as I said that when we are displaying the services that are offered by the hospital, we talk about those that are provided and those that are not provided. I gave an example of oncology. Oncology is not provided by KM. So we write that not providing oncology service. Similarly, in dermat department, if there are certain services that patients will come for, but you are not providing it on your own, then also have exclusions. So inclusion में तो सब कुछ आएगा आपका जो भी आप कर रहे हो और exclusion में वो आएगा जो हम नहीं कर रहे हैं. Then again, the department organogram will come. So like I said, organogram may be different at the level of the OPD, at the level of the ward, at the level of the ICU. So we just list, and if it is the same, it's easy, copy, paste, copy, paste, copy, paste. But we need to put our thought into what could be the organogram, which is different in the OPD. Then we have, once you have defined the organogram, what is missing here is a staffing pattern. एक स्टाफिंग पैटर्न का टेबल बना देना और उसमें लिख लेना कि कौन कौन किधर किधर होगा इन दिस OPD. Then what is the role of the different staff, categories of staff in this organogram or in this staffing pattern. So in the staffing pattern for the OPD, everywhere HOD need not be there, right? But there will be always be an HOD because that is the approval or whatever we are reviewing authority for this particular manual. So you have to identify what will be the role of HOD. Like for example, I will say that review and approve the manual that is prepared. Okay, so what is the role of unit in charge? Role of unit in charge would be to see the patients who are referred and also to appoint on some difficult conditions. वो जो है जैसे लगता है, this is for each department to think and fill it out. Then we have what are the procedures where when I say described, I don't mean to describe it in text running into 10 pages. It just can be a simple flow chart or it can be bulleted text. Okay. So how does the patient get registered? So what is the procedure for registration of the patient? Does the patient have to pay? वो तो 10 रुपया का पावती निकालना पड़ता है अभी भी OPD में, तो वो कैसे होता है? Then inquiry relating to concerned doctor. So if you have multiple doctors, like for example, dermat, there are 2 units, I think. So if the patient wants to see the other unit, so where this will happen, where can the inquiry be done? Then what is the OPD workflow for new patients and what is the OPD workflow for follow-up patients if it is different? Then if there are any health schemes under which these patients can also be referred. So that also needs to be listed out. This is more important, I think, for the indoor patients as compared to the outpatients. But if it is applicable, please mention about it. And then what are the criteria wherein the OPD patients get admitted to the ward? So one is the criteria for admission, and then how is the procedure for admission will come in the dermat indoor. And what are the annexures for this? Then, like I've already discussed, the quality indicators that are relevant at the level of the OPD will be this: turnaround time for consultation. So he's been waiting, he's made a paper. So the other thing that we need to kind of incorporate in our OPD paper is the time in. So when HMIS comes, which is getting rolled out, I think through that Railtel or something, if I'm not mistaken. So this should settle. But until then, how we can do this is something that all of us should collectively look and see how best to implement this turnaround time for consultation. That means patient made a paper at 8:30 and the doctor saw him at 11:30. Now, what I want us to be on the same page, or even if you're on a different page, if it is better, please share with all of us is let us not should we define the time frame so that every patient should be seen at least within 2 hours. If we define a time frame as being at least within 2 hours, then we have to see how many outliers are there. So on an average, I think we have, including both new and old patients, we have about 7,000 OPD patients in the multiple OPDs that we have. I'm not talking about a single OPD. So single OPD, I think new OPD 200 to 300, old OPD also the same number. So there's a number like 500 to 600 might be there. So is it possible to do this on all days for all the times? No. So you can have define a day in the month, one day in the month where somebody is tracking this, and it cannot be your own department, right? So we need to identify who will track the turnaround time for consultation in, let's just say, skin OPD, dermat OPD. Then patient satisfaction score through feedback form. So this feedback form is something that can be done in two ways. You can do it proactively or you can do it passively. What do I mean by passive? There's a feedback form, dabba that is there, prominently displayed in the waiting area. There are papers and pens provided, and then there is somebody who can talk to them and say that, would you like to provide a feedback? So that becomes proactive, and they are doing on their own, that becomes passive. So it is important that patient satisfaction score is gathered. You don't have to gather for all the 200 patients, but even a few in a month. So suppose we get 30 feedbacks also in a month, where every day you're seeing 300 patients, should be sufficient to begin with. They probably will just look at whether we are having a mechanism in place to do that, and whether we are doing it, and whether we are analyzing. It's not just about capturing things, it's also about analyzing and monitoring the trend. So the patient feedback in the month of, let's just say, April, was not so good. In the month of May was not so good. Then you analyzed it to find out what was it that was not, that they found was could be improved. Then you put in those intervention measures. Then you see what is happening in July and in August and in September. So by September, over 6 months, even if you can demonstrate that the feedback improved, it is good. If the feedback did not improve, then you have to really sit back and think what went wrong. Okay, so it is true for all these things. Then there is medication error. That is something, OPD level, we don't disperse the medicine. So this will go to the dispensary. All of us have dispensaries, right? So if it goes to the dispensary, then who is going to monitor the medication error rate? So
Gita
at
ma'am,
the sorry,
sorry. Are you sharing the SOP, because we are not seeing it here?
am I not sharing the SOP? I'm sorry.
Yeah, yeah. So yeah.
Wait.
So maybe you will have to stop share the previous thing and share it again.
बराबर है.
I'm so sorry.
No, good you pointed out, because I thought I was reading it from there. Aram se.
Yeah.
Okay, so I'm looking at dermat OPD SOP. अब दिख रहा है?
Yeah, perfect.
I'm
And ma'am,
really sorry.
yeah, no,
I
no,
will
no.
just,
And
I will just scroll through quickly
yeah,
what I already said.
yeah.
So because a visual, I always feel it is my way of looking at it, that when there is a visual thing also, it becomes more ingrained than only a verbal thing. So this is how the usual format of the thing will be. I spoke about a department code, the version number, the version date, then the control of the manual, then the document is prepared by whom, reviewed by whom, issued by whom, and approved by whom. Approval has to be the dean, and review has to be by the HOD or anybody senior in the hierarchy can do it. Then the next thing is define the scope of the department. What all kind of conditions would you see in the dermat OPD? So what are the conditions that you would not be seeing, not be able to see with the current facilities that we have? So inclusion and exclusion criteria for the scope of the department needs to be defined. Then have a department organogram. Then role of each. So what I also mentioned that what is missing here is the staffing pattern. So prepare a staffing pattern that is always nice. So you know that these are the many different categories of persons who will be posted in the OPD, and what is the role of each of these persons at that OPD needs to be defined by each department. So it cannot be stated like that. Maybe the dermat department of all four medical colleges can sit together and do this, but we already have made one, so you could talk to the dermat department here, or best still, your NABH facilitator can help you with that. So the procedures for registration, billing, if there is any billing, inquiry, the workflow of follow-up patients. What is missing here is the workflow of new patients. Then if there are any health schemes, government health schemes, which can be made use of by the patients, and what are the criteria for getting the patients admitted from the OPD to the ward. So this actually should be there in every single SOP, right? And we were here talking about the quality indicators. So the first one I spoke about was the turnaround time for consultation. So this is something that cannot be done on a daily basis, and therefore somebody else can come and do it once a month. Your NABH facilitator will tell you what is the best thing to do for each of your settings. So like Dr. Yuvraj, all I'm trying to tell you, I don't know if Amit is there from Sion, and there is this person from Cooper also. I'm sorry, I haven't gotten your name. So suggestion is that if you can have somebody who can come once a week or maybe twice a month also, all these things get क्या बोलूं, the format becomes clearer, it gets expedited, and our person also helped review what was being sent and gave us feedback. Like for example, if Dermat sent them initially the SOPs based on the format that was provided to us, then she would say that this is missing, add this, and then it got completed. So that's what I mean when I say that they usually know what is required, and they look at those areas which are likely to be missed, and they tell us that this you have to incorporate also. Then patient satisfaction, I spoke at length. Then there is this medication error rate which needs to be done at the level of the dispensary. Now I just want us, I'm thinking about something that we really don't have. We all have dispensaries, right? Where medicines are getting dispensed, correct? They are getting dispensed based on the prescription of the doctors, yes? Somebody can say yes?
Yes, ma'am. Yes, ma'am.
Yes. So in which case our dispensaries becomes pharmacies,
Yes.
and they all need licenses,
Oh.
right? So the problem is when we started off with this about 3 months back, so we have then applied to the FDA, because you have to go to FDA for a license, and the requirements for a pharmacy is too huge. So what we fortunately have are all the pharmacists have pharmacist license. But
Okay.
the site from where the dispensing is happening, the dispensaries which are there in all the different buildings, there's one in the CBDC building, one in orthopedics, one in OPD building, they don't have a license yet. So this is a thing that the admin has to work for us and give us a solution. Okay, otherwise it becomes very difficult. We may, unless we have the pharmacy license, we may not be able to proceed at all. But we
Yeah.
are not stopping because we don't. That's what I said in the beginning itself. Don't stop because there's a jam. Just circumvent it. You know that there is going to be a jam. Just circumvent it. Complete the rest, and highlight and forward that jam to the administration. कि ये वाला problem है वो solve करना है. Then percentage adverse reactions, drug reactions, compliance rate of medication in capital. Okay. So another change that has to be brought in place, and the clinicians might find this a little difficult to begin with, is all your prescriptions should be in capital. And you have to use certain terminologies like BD, OD, etc., etc. Instead, you have to switch over to 101, 010, 111, like that. So all these things need to be corrected and implemented. Then patient fall rate. This is same that I have already spoken to in that indicator slide, and incident report. So proceeding further, then you describe. So every OPD in the beginning, they're not expecting you must be seeing 100 different kinds of conditions in your OPD, but you don't have to describe every single one of them. So if there are 100 conditions, take 10% of those and describe them in detail. So whatever be the number of conditions that you see in your OPD, take the 10 most common ones, 10% of the most common ones and do it. Similarly, if there are any critical kind of patients who you identify at the level of the OPD, how you will identify them. Medical emergencies, that also you need to list out. So this is what it is. So at the level of the OPD, we start with the registration of the patient. Purpose is to register the patient to coming to seek treatment. So responsibility, this we have to kind of tweak it, right? So at our level, it is not the responsibility of the OPD staff nurse or reception staff. Registration of OPD patient is done at the registration counter. So we have to tweak all these things uh, to suit our institute. So whatever is happening at the level of the, because we don't have a concept of receptionist at all. So whoever is doing it at the level of the registration counter, we have to identify and designate, give them a designation and do accordingly. So what is the end point of the registration process? So every single process should have an end point. The end point of the registration process is patient gets an OPD file. In our case, I think they just give a paper. I don't think they give a file. So there is an OPD paper which mentions the name, the registration number for that OPD, and then the unit head. And what I said needs to be incorporated is the time the paper was issued. I don't think that's happening now. Okay.
For
So,
Nair, it happens because we have
good.
HIMS. Yeah.
You have HMIs at the OPD level. We don't, we actually have, I think for the indoor patients, things are getting recorded, but I'm not so sure about the OPD patients. I don't think it's happening to all.
For indoor, it happens at KM, ma'am, because
Yeah, indoor I know. I'm talking about OPD. I don't think it happens for all. Time the OPD paper was issued does not happen for all. And it's not just about the time that the OPD paper was issued, it's also the time that the person actually comes to the OPD. Oh, chai pee ke aayega. So what do we mean by consultation time is the time that is taken from the time the patient comes to the OPD till he is seen by the concerned clinician. It could
yes.
be JR1 also. That is not the issue here.
Yes, ma'am.
Okay.
Yeah.
Then, therefore, every SOP that you prepare will have an output in the form of records. Every single SOP. Okay, so there are certain records that need to be generated for every SOP. So for registration and the patients being seen in the OPD, you will have records in the form of attendance record. तो ये तो हम मेंटेन करते हैं कि नहीं मुझे नहीं मालूम करना चालू होगा कि ओपीडी के बाहर रिकॉर्ड रखो और उसमें जो भी है वो आके साइन करते हैं ओके Then every month, doctors saw how many days the person was present, how many days the person was absent, is to be given to the administrative office. And then we also need to give, this is happening at the level of our MRD. MRD tells us कि कितने OPD, कौन से OPD में कितने patients, what is the average monthly that is happening for a given OPD. So that is available. So 1.9.3 is there with us. What we don't have is 1.9.1 and 1.9.2. And 1.9.4 is also available with us. So MRD has these records, so you just have to tap them. Yeah. So you have similarly OPD workflow, follow-up patients, which is going to be different from the new patients. Then inquiry relating to concerned doctor may be applicable, may not be applicable. So depending on that, we can describe it. The format remains the same. Name, purpose, responsibility, authority, specific environmental requirements, then any equipment that is needed for OPD workflow, follow-up patient, and what is the method. So just this kind of a thing, if your NABH facilitator also does the same thing, it's the same. So how am I looking at this? I am looking at it in the form of, this was what was initially conceptualized, I think, but it didn't work out. I don't know, because all of us decided to stop at some point and we at KM decided, no, let us just continue to work. Okay. So that is why probably there is some amount of gap between KM and the other institutes. So the easier thing also could be that if you could speak to your counterparts in KM, and if you have something in addition you can help with, then it can be a combined thing, because things usually don't differ so much in terms of the generic SOPs that we are preparing. I don't know if you agree, go ahead. If you don't agree, it's okay. And then this is what I spoke to you about, that what are the equipments that are there. That should also be there at the level of the OPD. What will be there? There will be a piling. So we are talking about dead stock also here. That is how we call it in BMC, right? All these filing cabinet and all that comes under dead stock. Whereas there are the clinical care related equipment. So that is the BP apparatus, stethoscope, knee hammer. So what are the equipment that also needs to be listed up? And if we are, every SOP will have a format. I want you to take this format from the lab guys. They have this amendment record. So that is something that is easy, and it has a general format. So this was about OPD. So is this okay? So now I think I will stop sharing this, and there is about indoor.
Yes, ma'am. We have time till 3:40 because I have also hired somebody else's Zoom. So
हाँ हाँ
3:45 we have to end.
डर्मेट ओपीडी वार्ड का देखते हैं हम. So the format, if you see, remains the same for any SOP, okay, of whichever department. So there is a header, then there is a control, then there is prepared by, reviewed by, issued by, approved by, okay. Then what is the scope of this award ka thing? What are the kind of patients that you admit? So here it is important to mention that you do not admit certain types of patients. For example, you have a patient suspected of cholera and whose stool for hanging drop is showing dartingly motile organism. So that is an exclusion, right? So patients of cholera in medicine department would be an exclusion. Rabies in surgery would be, or medicine would be, an exclusion. So similarly, you will have criteria for exclusion. Bachus with suspected pertussis of diphtheria bacilli seen on primary smear are transferred to infectious disease hospital. So you need to write what is included and what is excluded very categorically. Okay. So I don't know whether in dermatology there are any exclusion criteria in the ward, maybe leprosy patients. I really don't know. So they need to give a thought to what all patients they will always admit and what all patients they will not admit in the said institute, but have a mechanism by which they can be admitted in some other institute. Then again, our organogram, what is missing here is staffing pattern. Then the role. So the format remains the same. Okay, so what are the various things that come under indoor SOP? One is that indoor means patient is getting admitted, right? So what are the criteria for admission and what are the criteria for discharge and what are the inclusions and exclusions? Both need to be there. Inclusion criteria for admission, exclusion criteria for admission, inclusion criteria for discharge. If there is any applicable exclusion criteria for discharge, that also. And a DAMA also needs to come. I think it is coming lower down. Then assessment. So when we said that we are talking about chapter 1, chapter 1 I said was AAC, right? AAC stands for access, assessment, and continuity of care. So in assessment, there are two types of assessment. One is what is called as the initial assessment, when the which all this is getting captured in our indoor forms. So when the person comes in, you're writing down everything about the patient, about the chief complaints, about the past, about the referrals, tests that need to be done, and about the treatment to be given. इतना तो हम करते ही हैं. उसके बाद में there is also a mechanism by which patients are reassessed, right? So at the end of every shift, so you will have defined mechanisms at the end of every shift, or if the patient, or earlier if the patient condition worsens. So that is the reassessment of patient. So regular assessment is happening every day if the patient is stable. And what should I say, more frequent assessments are happening if the patient's conditions worsen and it is immediate. So stable patient will have a reassessment schedule that will be different from unstable, critically ill or seriously ill patients. So this includes not just the initial assessment, but also the protocol for reassessment. So in this assessment, what will be assessed, who will assess, and how often? That needs to be defined. Okay, so in assessment, I said there are two types of assessment. One that is done by the nursing and the other that is done by the clinician. So nursing वाले क्या देखेंगे? वो देखेंगे temperature, pulse, blood pressure, जो भी अभी कर रहे हैं ना, weight, body weight, whatever they are doing at their level now, you need to include. Okay, so we have had this discussion and it has been a gray area, and I have tried to kind of circumvent it in a manner that there are clinicians want nurses to do additional things. Nurses say these are not the things that we do. So let us not create a friction between the two major categories of healthcare staff. There are multiple categories, I understand, but these are the ones that are closely related to patient care. So whatever they are doing now, let them please do. And whatever they are doing happily, let them please do. So if you want them to do in addition, talk to them. If they are agreeable, do it. If they are not, then whoever else is doing it has to do it. Then medication administration is something that the nursing people are doing. So what is the protocol for administering medication? Then transfer of the patient, if the patient needs to go to the OT. So transfer of the patient to the OT. What is the procedure for transferring the patient to another hospital? Then transferring the patient to ICU, transferring the patient to PT. Their OT is not occupational therapy, it is the operation theatre. Then receiving a patient, so then patient comes back to the ward from the ICU, so receiving a patient from ICU. Then when will you discharge the patient from the ward? What are the criteria? And all these fall in ward. So fall incident is something that you capture at the level of the indoor ward, which I have already stated earlier. And what is the procedure if the patient dies? Then if there are any chemo, so there is a special category of drugs if you're giving, then what, one is the chemotherapeutic drugs and the other one is I think narcotics. तो उसका क्या प्रोटोकॉल होना चाहिए वो प्लीज डिफाइन कर लीजिए. Then pain management कैसे होता है? So pain is a separate entity that the NABH is looking at. Okay, it's also one of the key performance indicators. So pain management has to be well explained. Then how is the patient referred for investigation? So, so if for indoor patients, fortunately for us, I think we are sending the samples to the various laboratories, and some of the samples probably are outsourced. So you need to have list of investigations that are done in-house and list of investigations that are outsourced. Okay. Then for that outsourced, if okay, so Dr. Yuvraj and others, for anything that is outsourced, you need to have an MOU. So if it is getting outsourced to a lab, private lab, which you decide on your own, then there has to be DIN sanction for it. So some kind of a mechanism needs to be in place for things that I am not. 1 minute, huh?
Is one later from Mumbai.
Okay.
Just need one.
Take it from somebody else, na, please.
Okay.
Then record keeping, then handing over. So record keeping at the level of the ward, we all have an excellent register that is maintained indoor. The sister in charge and the staff nurses, circle nurse or staff nurse usually maintain it very well. The only thing that needs to be added, what I thought was the initial assessment time. Okay, so वो वाला अभी उधर कैप्चर नहीं हो रहा है. उसके लिए एडिशनल कॉलम बनाने के लिए जगह नहीं है, तो जहां पे भी थोड़ा जगह है वहां पे डाल दो कि इनिशियल असेसमेंट टाइम कितना था. Then this isbar thing handing over at the end of shift. So that is the isbar thing, that isbar was followed करके लिखेंगे तो भी चलेगा. And the person who comes in to take over from the handover should write that scene. Okay. Then waste management in the ward का SOP होना चाहिए. तो हर एक ward को अपना अपना बनाना जरूरी है, because you know what kind of a waste is generated at your level. It could be different in it would be different in dermat ward, and it would be different in medicine ward, because you have patients with a lot of superficial and deep skin infections in dermat ward. So you'll have a lot of yellow compared to red, whereas in medicine ward you'll have a lot of red compared to yellow, and in labor ward you'll have mainly yellow. So based on that, every single area department should have its own SOP. I wouldn't say ward wise, but department wise, you need to generate an SOP for biomedical waste, and this is mandatory. Okay. Then you have process for DAMA. What is the process? So in our discharge card, Dr. Yuvraj and others, we have everything except DAMA का जो है वो कुछ नहीं है उधर mention. Please check back on your discharge cards. We need to have one format for discharge irrespective of what we are, unless it's a specialized it's a specialty where additional information would be required. Like for example, I think Oftal wanted to have वो जो उनका आंख का picture के साथ कुछ discharge card रहता है. So you can have more than one format of discharge card also, but in general keep it uniform. Then a DAMA process needs to be process for DAMA also has to be defined in indoor. Then policy on verbal orders. So are you okay with, so the dermat people and all clinicians need to kind of come to a consensus as to verbal orders. Abhi phone pe aapne bata diya, right? So ye karo, wo karo. So is it something that is acceptable? Then patient attending system, there has to be call bells. Then we have the requisition forms in plenty, so that is not an issue. Then sample collection and reports handover. So that also happens, I think, fortunately well. And indenting the watchdog. So the sister in charge has a watchdog register. So if you see, there is a whole list of SOPs at the level of the ward, at least 44 of them. So I can share this list of SOPs for the ward, for one particular ward, which will more or less be the same for all the wards. And also please take inputs from your NABH facilitator. Maybe if she finds that this is not required, this is required, etc., etc., you can make accordingly changes. Will this be okay? Can somebody please
Yes,
answer
ma'am.
that?
Yes, ma'am. Yes, ma'am. We'll be
So I
very
will share,
thankful.
I'll share this. So at the level of the ward, the quality indicators again remain the same with the exception that you have to have a time for initial assessment because that is, I think, the first or the second key performance indicator. Okay, so वो कैसे करना है, like I said, in the ward कैसे करेंगे वो देखना पड़ेगा because maybe it is not possible to capture for every patient, so you can say that once a week you can mention. So that's something that you can speak with the NABH facilitator as to how often do they expect us to want. Should it be for every patient? If it is for every patient, then how will you go about doing it? Right now, we are considering that we will do it for every patient, but we will know over a period of month. They will come back and tell us, madam, it's just not possible because I've already started hearing those words. So we have to have a plan B in motion as to if it's not possible, then what proportion of patients it should be captured. Okay, so I don't think NABH looks at 100%, but even if 70% compliance is there, should be sufficient. Though they are looking actually at 80%. तो बाकी सब वही है, percentage blood transfusion reaction, percentage adverse reaction, percentage error medications, then incidence of pressure ulcer, corti-CR base as applicable to that particular ward. But once you come into the ward, hand hygiene compliance is extremely crucial. So they expect us to use the WHO checklist, and it is the easiest thing to do. Okay, so the WHO checklist is very self-explanatory. It describes the 5 moments of hand hygiene, how many opportunities for hand hygiene were there, and how many opportunities were complied with. So we have shocking results. We have very happy results. So you will also go through the same phase of being in shock and awe at different times of the day. So that is something that will happen. And this is another thing that we need to kind of highlight to the admin is the nurse to patient ratio. So currently NABH says that you need to follow the nursing council standards, and the nursing council standards say that for any other, for most wards it is 1 in 6. Then for some types of wards it is 1 in 4. Then for ICU it is 1 in 2, and for ventis it is 1 in 1. So we need to take a call, and this has to be over all 3 shifts. So we need to take a call as to what proportion of this are we complying with. And for this, you need total cooperation from the matron because she is the one who assigns. And one crucial thing that is happening here is the training component of the nurses. Suddenly, a nurse who is working in pediatric ward is posted to the operation theater, right? Without showing any evidence of having been trained for the operation theater practices. So every single department has to incorporate the training component for the nurses, and the nurses themselves can do it. The matron and the assistant matrons can take care of this with a little input from the clinician. So please consider their training. Just as, is there any lab person here? I saw Dr. Reena here. Are you still there? Some time back. Anyway, so for lab, we have a concept called as orientation training. That is when you come to the department for the first time, and then there is an induction training. So this concept of induction training has to be ingrained into every department for every staff who is newly posted in the department. You have to have this. There is no escaping this. Then there is this needle stick injury. All of us fortunately have a needle stick injury protocol which works very well. Then there is appropriate handover. Like I said, is bar followed, not followed, compliance rate of medication in capital. So you can have an intermittent audit of the medications that are being written and then see how many of them actually write in capitals and in the way it is expected to be written as 101 and not 1 BD or 2 BD like that. Then the other things like patient fall rate, percentage, near miss, time taken for discharge, and delining of tubes. Thrombophlebitis, restraint related injury, and any incident. And if there is any incident, then you have an incident report to be filled, right? And then you describe all the procedures, the 42 odd procedures that we spoke about when we started off with the list of procedures that are 44 odd. ये सबका procedure हमको describe करना है. Right? So this was about OPD level पे कैसे होगा हमारा SOP और indoor level पे कैसे होगा हमारा SOP. Now I stop sharing this and I go back to the initial presentation that I had. So before that, I think I want to take you through what is called as the Apex manual. Yeah, na? Dr. Yuvraj and those who are in the Apex committee of this is your job.
Okay, ma'am.
Okay, so this is something that you need to generate. Of course, you will need inputs from various other sections in the hospital and the departments, but it is totally your responsibility and you have to make it. So the initial parts remain this. The first page of all your documents will have a standard format. Do not try to deviate. Okay. So it could be this or it could be whatever is being suggested by whoever is trying to help you. So it could be the version. It starts off like this. The rest of the things remain the same. And the subsections include about the hospital. Right? What is the vision, mission, guiding principles and core values of the hospital? What are the various specialties offered by the hospital? So what you're going to be displaying as scope of services at the entrance. So that is something that will come here. Then what is instead of calling it as the board of management, we can call it as the administrative section. I'm not talking about the clerical part, I mean the hospital administrative section. Then the organogram. So our organogram is very well described. So we start off with the residents, we go to SRs, then we go to assistant professors or fellows, then we have associate professors, then we have or unit head, then we have professor and head, then we have dean, then we have DMC director, then we have DMC PH, and then we have the AMC, and then we have the MC. So the upper half comes in the administrative organogram and the lower half comes in the clinical organogram. Do organogram bana lena. Then what are the codes that would be there? So we have to have, there are 4 codes if I'm not mistaken. Code blue and code red is already something that I just spoke about, and then there is a code yellow and code gray if I'm not mistaken. What are the quality initiatives that are being considered by the hospital? The list of committees. So this you were interested in, Dr. Yuvraj, in that last meeting that we had. So I will just go through the list of committees. Key performance indicators is something that is already there in the NABH standard. So there are 32, 37 now, I don't remember. So just go through that. It tells you also how to capture the key performance indicators. It gives you the formula. Okay, so my suggestion is that start capturing it on a monthly basis and then take an analysis at the end of the month that there were so many, denominator is so much, numerator is so much, multiply by 100, that gives you the rate. Okay. Then regarding licenses, now we all get stuck with, we don't have that registration under the Nursing Homes Act, right? Does any of us have that?
No, ma'am. No.
Cooper has it? Is there someone from Cooper here? Anyway, so I have a document which was shared by, because finally the registration comes of or any hospital, whether it is ours or whether it is any other hospital, comes under Public Health Department. So I have a document that was shared by the Executive Health Officer of Public Health, which said that it is probably not required for us. So I'll share that document and then you can take a call subsequently. Okay. Then we have chapter manual. So there are 10 chapters and there has to be a manual for each of them. So you can go about, so basically these chapter manuals will only be policy statements. Okay, if there are 14 elements under AAC, right? There are 14 objective elements in the AAC. What is the policy of the hospital with respect to those elements? So that is what these chapter manuals would be for all the 10 chapters, 5 related to patient care and 5 related to administration. Then about KEM hospital. So this in short is the content of the Apex manual. So I'll share this page with you, Dr. Yuvraj, and you can post it in your group and people can start working. And if you have any additional points that are being informed to you by other experts, then please do let us know also.
Sure.
Yeah.
Yes.
So ये हो गया अपना Apex manual. Then I'll go to one of the committees. Okay. Because there is a same format for all the committees that we need to follow. So in that Apex manual, you will have to define the, you will have to define again, like any organogram, you will define the responsibilities of the higher management. So these are the list of committees. It could be more than this, but this is what we are working on. So one is the Apex committee, which you all are already a part of, I guess. There is something called as a strategic planning committee, which I think can be clubbed with some other committee. Similarly, we have a quality committee, which I want to club with safety and disaster, because we don't have so many people to become members of so many different committees, to meet so many different times in a year, prepare records, have minutes and follow up. So we can combine and merge, and finally we are left with about 10 or 11 committees. But some individual committees that can be looked at is mortality and morbidity committee. Keep that separately, because that tells about the quality of care that is being provided to the patient. Then the MRD records committee can be combined with something else. Then there is this infection control committee, let it be standalone. Ethics committee we all have. I don't think we have any grievance and disciplinary committee. I'm not very sure. Then we don't have anything like promotion and compensation committee. So that is a gray area for us. But we do have policies of when a person will get promoted and when a person will get compensated. So that we will have to take from but for sure committees that we must have is the Apex committee. We must have, if you're talking about patient safety and quality, we must have a strategic planning committee. I'm still trying to understand. If any of you understand it better, please let me know. Then there is a quality and safety committee. So combine the teen number with this number. Then there is a drugs and therapeutic committee, mandatory. Don't club it with anything else. Then we have condemnation committee, can be a part of the disaster committee, because things that are not operational should be condemned. Then there is a blood transfusion committee and mortality morbidity committee. These two can be combined, because in general they are adverse outcomes of something that is done. Operation theatre committee has to be different and include all the operating departments. Please don't just leave it to one. So let the committee be represented by one person from each of those departments. Then we have the MRD records committee. So that has to be specifically separate, because a whole lot of information comes from them. And if you have the HMIS, Dr. Yuvraj, I think it will be easy for you for this. Infection control committee, abhi jo bhi hai, they are functional in at least all the 4 medical colleges that I'm aware of. Only thing is the manuals and the records that we need to generate are more. But right now the records are being generated. This is for those who are attending from microbiology or infection control committee. The records are going to be generated peripherally. Okay. And our job as members of the infection control committee is to monitor what is happening in terms of the various hospital-acquired infection rates, including hand hygiene. Then there is a prevention of sexual harassment. All of us have this. Ethics committee, all of us have this. We need to have a grievance and disciplinary committee. So combined, we come to about 10. Okay. So now let's look at what are the basic subheadings of these committees. Every committee should have the objective defined. Like for example, Apex committee, जिसमें Dr. Yuvraj will be a member. So objectives are to involve the top team into, so corporate citizenship roles वगैरह is meant for corporate hospitals. So we make it and tweak it with respect to what we need to do. Then creative collective ownership for the results. Okay, and develop an effective next line of leadership. So this is basically the objective, the core purpose. So under these headings, we need to prepare for each committee and we need to designate members as per designations and not as per name. Okay, so the objectives, hoga one part of it, core purpose will be the second. Scope of the committee, what will it do? So those things are defined here in multiple bullets, about 12 of them. That will be the third. There will be members by designation as applicable to us. Then there will be who will be the chairperson, and also this does not mention, but I would suggest that we should have a secretary for each committee. Okay, because unfortunately or fortunately, if you look at any committee, the chairperson tends to be the dean, and the dean may not have time all the time to be a part of every committee, attend all the meetings, etc. So we can always have a co-chair and a secretary. So that I leave it to each institute to decide. When there has to be a quorum. So what number from those that are a part of the committee will be considered as adequate for us to conduct that meeting? So for every committee, please define the minimum quorum that is required. Then also define how often this committee will meet. So like for example, Apex committee needs to meet only once in 6 months. So since we are beginning this activity, you have to show one record. So you have to have an Apex committee form, define the roles and responsibilities of all the higher echelons, and then meet at least once in the next 6 months so that you have record of what the Apex committee is doing. Then there is a secretary, fortunately here that is mentioned, but it is not mentioned in all the committees. So that is the basic order in which it goes. Objectives, core purpose, scope, members by designation, the roles and responsibilities for the members, the quorum, the frequency of meeting, and the output. Output of the meeting, you can have a format. So can it then just stop here, please? Do you want me to share any of this?
No, ma'am, that's fine. My doubt was about key performance indicators. I didn't get it exactly.
Okay, so do you have that guidebook with you in front of you? Okay, Yuvraj, can you send somebody across to KM? I can provide you a copy and then you can purchase your own. Right? All right. Can you hear me?
Yes, ma'am. Yes, ma'am. Yes.
So I will just go through one key performance indicator and I don't know, let's just say give me some time, I'm going through the record, the book. So that is coming as annexure number 1 in that NABH guidebook to NABH accreditation standards. I will minimize this. I'll have to stop sharing this.
Yeah, that's fine.
Okay, so this is the book.
Yeah.
Okay.
Yeah, we have.
So,
We have.
and then this is the key performance indicators.
This is chapter.
This is annexure 1.
Annexure 1. Okay.
Annexure 1 on page number 278.
Yes, ma'am. Ma'am, that's fine. That we'll.
So it is there. Like for
Yeah.
example, time for initial assessment is
Yeah.
the time shall begin from the time that the patient has arrived at the bed of the ward till the time that the initial assessment has been completed and documented by a doctor. Correct. So they are saying that sum of time taken for the assessment upon total number of admissions. So suppose there were 30 admissions on a day, and then the time for assessment, let's just say, is 10 minutes, 12 minutes, 13 minutes. I say, oh, 30 patients. Ka. So total sum of time taken divided by the total number of patients, and that should be in minutes. And to be taken, frequency of data collation is monthly. So this shall be captured either through the HIS, which you are fortunate to have, or through audit. And in case of audit, the sample size shall be as specified in the sample size calculation table. So they have given a sample size calculation table also towards the end. So we need to see where we fit in as a hospital. So we have the 2000 bedded hospital suppose. So what is the sample size that we need? तो वो भी दिया हुआ है पीछे कहीं कि हमारा सैंपल साइज कितना होना चाहिए.
Okay.
तो वो भी देख लीजिए आप, तो उसके मुताबिक कर लेना.
Yes, ma'am. Yes, ma'am. Madam, thank you so much.
Yeah.
For throwing light. Rather, we were not, to be frank
No,
with
I
you.
still want to share one slide. No, don't.
Yes,
I don't leave things so easily.
Yeah.
शेयर करना है ना मुझे. एक लास्ट स्लाइड में दिखा देती हूँ because you also said that what is the road ahead, right? And where is it? This one. So we saw the dermat SOPs. Committees we have seen. Then what should be the committee ka thing? Then these are the manuals that we need to have. So we have what is called as an Apex manual, which I already kind of showed. Then there is a safety manual that we need to prepare. There is a quality manual that we need to prepare. Department manuals will be starting from 2nd of May. If I'm not mistaken, for all of you, we are already having department manuals almost nearing completion for 60% of the departments. And there is an HR manual. I don't know who will ever make it, but that's something that we need to coax the HR people to do it. Then these are the records that come as a consequence of all these activities, and we need to have 6 months data before we can apply. So that's why I wanted to show this slide. You were talking about road ahead, that we need to have these quality indicator records, key performance indicators, 6 months data for all this. We have to conduct an internal audit. We have to conduct a safety audit. We have to complete all training, including the training for basic life support and advanced cardiac life support. So this is the road ahead. I leave this slide. If there are any questions, I'm willing to answer. Others, I think we are almost 3:30 now.
We have time till 3:40, ma'am. We have time.
You want me to quickly go through these points?
Yeah, yes. Ma'am.
So the general opinion, the general understanding that I got during our last meeting, Dr. Yuvraj, was the fact that we have all gone through the chapters, right? We have assigned chapters to different people, and then we have gone through it, and then we have conducted our own audit, and we have found the gaps. No, I want us to reread the chapters. Based on whatever little we have shared now, just reread the chapters. And what I want us to do is to identify what is the output from each chapter that is required. So we have just done it for chapter 1 and chapter 2, right? So there will be so many more outputs that will come from the remaining 8 chapters. तो वो एक कर लीजिए आप, रीड कर लीजिए, not just for reading but also to find out what is the output that is expected and what are the key performance indicators related to that chapter. उतना कर लीजिए. Then this you have already done, designate nodal officers and ABA champions. Just give them the designation of champions. So let the head of the department write on a paper that these are my nodal officers and these are the champions, and keep it as a record in their this, and send a copy to you as the Apex committee member.
Yes,
Then
ma'am.
complete the required documentation as per format and compliance. So compliance is something that is best addressed by an NABH working person. It is not something that I and you probably can talk about. At least the format, generally what we are doing now, I have shared. Then important to document the training. So training on the documentation, depending on the category to which the training pertains to, should be completed, and we need to maintain records. There is no two opinion about that. So training records with the department and one to the Apex committee. So you have to accept a lot of things now. Then post training, a one-on-one verbal interview can be conducted to kind of, we can call this as understand back whether they have understood whatever training was imparted. Then please start this training on codes and crash card immediately after vacation. Right now I know that there is a crunch of staff, but after vacation I think we should concentrate and complete this training on that code blue, code red and crash card. Then responsibilities of management is yet to be defined, that we have not done yet. Then conduct internal audit. So there are 2 levels of internal audit that I am looking at. One is the first one that will be conducted by the same department, which is self-audit. And then it will be conducted by another department from the same institute, that will be the actual internal audit. तो उसमें से जो gaps निकलेगा उसको हमको address करने पड़ेंगे. And a safety audit should be conducted simultaneously. So what becomes a part of the safety audit, I will share with Dr. Yuvraj, then he can share it with all of you. Then human resource management, who is going to do and how, I don't know. Then information management system, when or if we are going to continue with the physical records and how best to have a mechanism. Basically what they are looking at is how well the things are captured and how can you track back, right? So patient records. So whether there is a good tracking mechanism by which if I say that ये patient का ये वाला paper दो, ये तारीख में जो admit हुआ है वो निकल के आता है without much ado. Then requirements that we need in terms of complying with NABH, please send it ASAP to the administration locally. I think that's about it. Best wishes to all of us.
Madam, thank you so much. It was uh, the hard work you have put in for the NABS thing and for this presentation both. Thank you for this.
Sure.
We had no idea of almost like 60-70% of this. We just distributed the chapters among staff members. And I think the clinical staff members who are attending this, they also have realized that we have a huge task of preparing the.
But it is not what I have realized, no, Dr. Yuvraj, it's not an insurmountable task. Okay.
Yeah.
So there is a format that is shared. If that format is shared, you know what needs to be put in. So it takes about 2 weeks. And once you have that format in place, then you just get it, what should I say, vetted by somebody who knows what is required.
Yes.
So within a month, your SOPs are ready. Documentation gets completed. But uska jo records निकलता है वो उसके अगले महीने से होता है.
Thank you. If you can share some of the soft copies, then maybe we can.
Yeah. Like I said, Dermat ka OPD ka format and indoor ka format, Apex manual format, and the list of committees I will share.
So we will start working on this.
Yes.
Dr. Mahadev is also here with us. second nodal officer, and Dr.
Yeah,
Bharat sir
Dr.
is also
Madhav
there.
is there, yes. And then ऊपर से कोई है. NABH Dental is also here.
Yeah. So thank you so much. Anybody else has any questions?
नहीं है तो let's start working together and
Yeah.
then let's see how best to progress.
Yeah. Thank you so much. Thank you again, and thank
Thanks a
you for
lot. Thanks a
thank
lot.
you for all those 57, and we, at one point we had almost 670 participants joining in. So we hope that we all can just make it. Thank you so much, ma'am. Just wanted to ask you that your permission, because we may, some of them may like to see this presentation go through again. If we can, if with your permission, we can just prepare a private link and share it. We not make it.
Telling her the same thing PPT that I made.
Yeah. No PPT. The PPT also you can send if you want, and
Or you were talking about
the,
the video recording.
recording
चलेगा ना,
will
चलेगा.
not put it on a public domain.
Please
Anybody
don't.
with the link can
Yeah, yeah.
watch.
Yeah,
Anybody with the link can watch.
Yeah, okay, fine.
Yeah. Thank you so much, ma'am.
Thank you so much.
Thank you again, everybody.